Today I'm going to be talking about menopause in older women. All of us are affected as women with menopause, whatever our age is, but so many people I speak to and hear from think that they've missed out from treatment, or that they're not allowed to have treatment, or that they've come through the menopause and they don't need any treatment. So I thought I would just do some myth busting for the next half an hour. So for those of you who don't know, menopause occurs because our hormone levels decline. It's actually been described as a year since our last periods, but actually I don't feel that's accurate enough, because what we need to do is think about our hormones, and we have hundreds of hormones. They're chemical messengers that go in our bloodstream and go all around our body. But when we think about menopause, we're only thinking about 3 hormones: estrogen, but actually estradiol, because estrogen is different types of estrogens, and it's estradiol which is the nice natural anti-inflammatory type of estrogen. So estradiol, progesterone and testosterone. These hormones are produced in our ovaries, but they're also produced in other organs, including our brain. But levels decline as we get older. They decline when our ovaries don't work as well, or if our ovaries are damaged or removed from an operation. So many of us will be menopausal at different times of our lives. The average age in the UK is about 51. In many countries such as India, it's younger actually. But when our hormones are low, they are low forever. And so some people, and many people actually, talk about it being a transition period. It's almost like we go through the menopause. Lots of people say to me, oh, my mother's got through her menopause, she's fine now. But actually what she should be saying is, my mother's got low hormones and they're going to be low forever until the day she dies, because that's what happens actually. When we think about menopause, it's when everything is low. But actually, the time before menopause, in the perimenopause, when hormone levels start changing, can actually be more turbulent, can cause more symptoms, and cause more problems for a lot of us, because our bodies don't like change. So once our hormone levels have finished fluctuating, they go low and stay low forever. Now, our body can adapt, of course it can, without the hormones. So that's why a lot of people find that their symptoms actually might reduce and lessen when they've finished being perimenopausal, but they will still be menopausal. So when I say menopausal, it's the same as postmenopausal. If you look at the definition of menopause, it's a year since our last period. So it's just literally a day. That's all it is. So whether people are menopausal or perimenopausal, in my mind, it's exactly the same thing. No one actually gets through the other side. And when we think about these hormones, it's not just about causing symptoms. As many of you know, our hormones are very anti-inflammatory, so they reduce risk of diseases, especially inflammatory diseases. Our immune system is primed to protect us, and we have receptors for estrogen or estradiol, progesterone, testosterone on our immune cells, so they can help fight infection but also inflammation in our body. So the big question is anyone too old for HRT? Does anyone have to stop it after a length of time? And there are many myths, and it can be very confusing when you look this up, and certainly if you start to Google, you'll be overwhelmed with different amounts of information. So I'm not going to go into hormones as in hormone replacement therapy in too much detail, because I've given a lot of information. There's other Instagram lives about this. But suffice to say, usually what we prescribe now are body identical natural hormones. So biochemically, they're exactly the same as the hormones we produce when we're younger. Usually we give these hormones separately. So we give estrogen, estradiol, as a patch or gel. So through the skin, goes into the bloodstream, stays as estradiol. Progesterone, either a oral capsule or a vaginal or rectal pessary. It's the pure progesterone, the same molecular structure as our own progesterone. And testosterone, either a gel or a cream. Again, through the skin, goes straight into our bloodstream, doesn't get metabolized by the liver, so stays as the pure progesterone. These hormones are very safe because they are just our natural hormones, and the doses can really be individualized for each person at each level, each stage they're at, and it's according to their symptoms, the way they absorb. And I've spoken before about the differences between different absorption and different doses that different people need. So when people are worried about starting HRT at an older age, or continuing HRT, then this is because of the synthetic hormones, which are the hormones that were used in the past, which are chemically altered. So if you think of the WHI, the Women's Health Initiative study that many of you will, I'm sure, heard of, this is actually made from synthetic, chemically altered hormones. So you've got estrogen, which was conjugated equine estrogens, CEE, a lot of people talk about. But conjugated means lots of different types. Equine is horses, and estrogen is obviously estrogen. So this was derived from pregnant horses' urine. It contained a whole array of estrogens, but also synthetic progestogens and some androgens as well. And goodness only knows what else was in this pregnant horse's urine. So it was also given as a tablet. Now, any tablets or food or anything we put in our mouth gets metabolized through our liver. Our liver's like a big sieve, and it sort of sieves everything that we have in our mouth to get rid of any toxins. It protects our body, of course it does. But anything that it doesn't recognise, it will try and change into something that our body will recognise, or it will see it as some sort of poison and cause a reaction, if you like, to the body. So we know that tablet estrogens do have a small risk of clots because our liver produces clotting factors which will increase when it's metabolizing these estrogens. But also there's a small risk of stroke as well with these tablet estrogens. The other thing, the other type of the hormone, or the combination part of the hormone used in this WHI, the Women's Health Initiative study, was a synthetic progestogen called MPA, or medroxyprogesterone acetate. Again, it was just chemically altered, so not the same as the pure progesterone. And we know that medroxyprogesterone acetate has a very small risk of clot associated with it, and a small risk of heart disease associated with it. It's quite inflammatory in the body. So when they looked at that study, they showed that there was a small risk of clot and stroke. When people started HRT more than 10 years after their menopause, so generally age 60 and above, they noticed there was a small increased incidence of heart disease and heart attacks in these women. And then, as everyone knows, they found this small increased risk of breast cancer, only with the combination type, so with the estrogen and progesterone, not with estrogen only HRT. So that got everyone really, really scared. Now, a lot of people talk about this window of opportunity. So if you start HRT when you're young, you can continue it until at least the age of 60. But then a lot of people say, well, if you're over the age of 60, you're too old, you can't take HRT, and that is not right. When you interpret the WHI study, which was the big randomised controlled study, and there's some of it is good data actually, but some of it has been misinterpreted, or also it's been misinterpreted for the wrong person. So if you look at some of the women in that study who were over the age of 60, a lot of them actually had heart attacks in the past, or they had cardiovascular disease, or they were obese. So they had risk factors for having another heart attack. Their makeup was not the same as somebody in their 30s or 40s wanting HRT. So you can't compare because they weren't like with like. But also, if you compare a 62-year-old who's not overweight, who's never had heart disease, who has normal blood pressure, she's not going to be the same as a lot of women in the study who I've already said were overweight, did have raised blood pressure, had heart disease before. But also, these women in the WHI study were given a type of HRT which we know increases risk of a heart attack. Fast forward 20 odd years, we don't give that type of HRT, we give a very different type of hormone, which I've already said is the natural estrogen, the natural progesterone, and if needed, the natural testosterone as well. So they've got estrogen, progesterone, testosterone, all natural. Now, if you look at the way estradiol, the nice active estrogen, works in our cardiovascular system, it has a myriad of effects. It reduces inflammation, it keeps the lining of the blood vessels, the endothelium, very thin. It reduces atheroma and atherosclerosis, this furry deposit. This atheroma is like a build-up of a fatty plaque that occurs due to inflammation. It also increases nitric oxide, which is a vasodilator. It opens up the blood vessels, so then it can also help lower blood pressure as well in a very natural way. It also has really good controls with the way our kidney works. So we have something called our RAS system, our renin-angiotensin-aldosterone system, RAAS, which actually, our body's amazing. It's constantly regulating the way that we have fluid retention in our body and getting rid of fluid to help the pressure in our blood vessels, because we need to have some blood pressure, otherwise we'd be fainting all the time. And if I stood up quickly, I want to not feel dizzy. And so we've got these baroreceptors that are constantly looking at seeing what our blood pressure is doing and how it equates to where we're standing, where we're moving. Like every time I move my head, I don't want to feel dizzy. So everything's in a constant equilibrium, and estradiol really helps with that. If we don't have it, that's why a lot of people can feel quite dizzy when they stand up, because their cardiovascular system isn't tuned quite as well. So the estradiol is really good for monitoring and helping and protecting our cardiovascular system. You don't get that same effect with conjugated equine estrogens. A lot of those estrogens are very inflammatory. They will worsen atheroma, they will further lining of the arteries up, and they possibly will increase blood pressure. But we know medroxyprogesterone acetate can increase blood pressure. Progesterone is very neutral on cardiovascular system. It's neutral on the blood pressure, probably lowers blood pressure as well, because we have progesterone receptors throughout our cardiovascular system. So it's very important when people are told, oh no, there's an increased incidence of breast cancer, there's an increased incidence of heart disease or heart attacks if women start taking HRT over the age of 60. That might be the case with older types of hormones, and certainly I wouldn't start anyone older on a synthetic hormone. Don't usually start younger people either, but older people I certainly wouldn't, because as we get older, we've all got an increased risk of clots, of strokes, of heart attacks, of raised blood pressure. That's part of aging actually. But what we want to do as clinicians is reduce those diseases associated with aging. And one of the ways we can reduce them actually is by considering hormones. So it's a bit paradoxical, isn't it, that we've all been told that HRT can increase incidence of heart disease, and if I open my patch insert, it will say risk of a heart attack. But that's associated with the older types of hormones, not the types that we prescribe now, because they're just acting in a very physiological, natural way. So we do see women in the clinic who have either never had hormones before and are keen to try, but they're over the age of 60, or that they have been on them in the past and then were taken off them because they were told you've been on them for too long, or you've got to 60, so you must stop them. So there's a lost generation of women who have never had hormones or been taken off hormones because of the WHI study. We have to remember, before 2002, HRT prescribing in the UK was about 30% of menopausal women. In the US, it was about 40% of menopausal women, and it was increasing. Overnight, people stopped prescribing HRT. And now in the UK, it's about 14% of menopausal women take hormone replacement therapy. And in the US, it's far lower. It's as low as 4%, a recent study showed 1.8% prescribed hormone replacement. That's nothing for something that has more benefits than risks. So there's lots of women who are now realising that maybe their quality of life can improve, maybe their future health can improve if they are given hormones. Because we can individualise the dose, often when we start prescribing for older women, we start with a very low dose and then gradually increase, so then their body can adapt and get used to it. Usually with older women, I'll start with the gel, because the gel is very easy to start low and then they can titrate and increase, obviously under medical supervision. And then when they find the dose that's right for them, they might prefer a patch, and then we can work out the dose equivalent, and then they can have a patch instead of the gel. It's obviously very individualized. And then the progesterone, we usually give the progesterone 1 capsule every evening. I think the best thing about menopause is not having periods. So the last thing a woman in her 60s, 70s, 80s or 90s wants is to have periods. Obviously, anyone who starts hormone replacement therapy can have some spotting or bleeding for the first 3 to 6 months after starting HRT, and we always warn people of that. But usually people don't, or if they do, it's very mild and it doesn't last for very long. Some people think that the hormones won't work because they've had so long without hormones. How are they going to work? And I was taught many years ago that there's some methylation of the receptors and they won't work as well, the hormones won't work as well. But actually in my clinical practice, I don't see that at all. And actually I've seen people who have had symptoms for 30 years following their hysterectomy. I saw a lady recently who'd had a hysterectomy at age 38. She was never offered hormone replacement therapy, and she's now 68, and she's had night sweats and flushes every single day since that time, and been told she can never have hormones. So of course she can have hormones, and actually within a few days of having some estrogen, her night sweats went, her flushes and sweats remarkably reduced. So very quick response. Some of Lisa Mosconi's work looking at the brain found that actually the brain responds quicker in older people who have had time without estrogen. And I wonder whether it's just like the body's a sponge, it's just waiting for those receptors to light up their body and brain and tissues again once they have their hormones back. Very little research has been done because very little research is done in general on menopause, but certainly our wealth of clinical experience that we have in our clinic shows that women respond actually very well when they started on hormones when they are older than 60. And these people we just monitor, but a lot of people find that actually they're sleeping better, they have less joint pain, less muscle aches, they have less urinary symptoms, they have more energy, their blood pressure comes down a bit. So a lot of those people we can actually stop some of their painkillers, their blood pressure treatments, some of their antidepressants, their sleeping tablets, other medication, and we do this very gradually. But in the clinic, we're all GPs, family physicians, general practitioners, and we're very used to looking at people with polypharmacy, as in lots of medications that they're on, and we always optimise and try and improve. But we often find that people really respond well, even older people. Now, I know some of you have asked about cognitive decline or dementia. What about that? We've got no studies, of course, but we know that our hormones, as I've said at the beginning, are produced in our brain. They're very anti-inflammatory. They work as neurotransmitters. They transmit signals from different areas of the brain. They can be very important in the way our brain functions. So we don't know about how it will work with people who already have been diagnosed with dementia. But I do have some patients who actually have taken their HRT at an earlier age. They've had some cognition problems, and they've found that taking hormones has delayed the progression of their cognitive decline, which is no surprise. We can give hormones in conjunction with other medications. They don't interact because it's just the natural hormones. So I'm not saying that any of this treatment is to replace another medical condition that's receiving treatment. It really is to go alongside. The same as if you'd cut your finger and had a headache. You wouldn't just put a plaster on your finger and forget about your headache. You would give yourself maybe some painkillers for your headache as well as putting a plaster on your finger. And that's the same with hormones. We're not giving hormones to improve cognition. We're giving hormones out of choice because people want to see if it will improve some other symptoms, but we are finding that cognition can improve. The other thing is as you know, osteoporosis affects 1 in 2 women who do not receive hormones over the age of 50. The incidence of osteoporosis increases and increases the older we get. We know from some studies that even a low dose of estrogen will help strengthen bones, reduce osteoporosis, and also, more importantly, reduce osteoporotic fractures. And so it's not unreasonable for women to consider a low dose of hormones to improve bone density and reduce incidence of osteoporosis. And so whether they take a drug for osteoporosis or not, they can still be considered for some hormones to help strengthen the bones and also the muscles. I've spoken before about osteosarcopenia, so that means loss of bone and muscle mass. Our muscles are really important, obviously, to keep us strong and healthy, and we know that muscle mass reduces without our hormones. So a lot of people I see who start hormones when they're older say that they've got more strength, they've got more stamina, they can exercise more, but they just notice that their muscles are stronger. They can reach the cupboard to get a tin down, they can cook in an easier way, they can get out of the bath, they can get onto the bus easier. All of these things are really important when we want to reduce fragility, we want to stay strong, and we want to keep our bones and muscles and ligaments and joints as healthy as possible. So the other thing to answer is, how long do I stay on HRT for? A lot of women have contacted me and said they've been told they've been on it for 5 years or 10 years and they've been told that they need to stop. Well, again, this is associated with older types of hormones, and this is usually because people are concerned about the breast cancer risk. Now, just to recap, the breast cancer risk is very low even with synthetic hormones. It wasn't ever shown to be statistically significant. The risk was very low. If you put it into context, if you look at the magnitude of risk of breast cancer, actually, the risk is actually lower compared to someone who drinks a bit of alcohol regularly, who doesn't exercise, or who is overweight, because these are modifiable risk factors for breast cancer. So we know that even those lifestyle factors will increase incidence of breast cancer more than taking any of the older types of hormones. But I've already said we don't give those types of hormones, so that risk of breast cancer is irrelevant. We're just giving natural hormones. And so there haven't been any studies to show there's an increased incidence of breast cancer in women of any age who take HRT. But the other thing we do know with good evidence that women taking hormones have a lower future risk of heart disease and osteoporosis, diabetes, other cancers including colon cancer as well. So looking at the bigger picture, we know that there are more benefits than risks for taking hormones. And so then it breaks down to individual choice, of course. The guidelines are very clear that women should be reviewed every year, and if the benefits outweigh any risks, then they can continue. But also, the patient has to be integral to that decision making. Many people take hormones to improve symptoms, but also many people also take hormones to reduce their risk of diseases. And this is where it's a personal choice. We review patients in the clinic every week and then we review them. Obviously we work every week, but we see people every year when they're stable for an annual review. And that's for 2 reasons. Firstly, to make sure that they don't have any new medical problems, to review their history, and to make sure that their benefits still outweigh the risks. But the other thing is to optimise their dose, because some people need their dose increasing or some people need their dose decreasing, depending on what their absorption is like, what their metabolism is like, what their symptoms are like as well. But we need to make sure that women are absorbing enough to really reduce that inflammation and keep their bones strong, their hearts healthy and their brain healthy as well. So it's not just a quick consultation to say, are you happy to keep taking HRT? It's looking at, are you on the optimal hormones for you? Do you need testosterone? Do you need progesterone? And I've spoken about progesterone, so even women who've had a hysterectomy or use a Mirena might benefit often from progesterone as well. And the other hormones to consider always when we talk about HRT is vaginal hormones. A lot of people with time are very stable with their systemic symptoms, but they're starting to get some cystitis, some urinary tract infections, some bladder dysfunction, or they might be getting up to the toilet to pass urine. They might be a bit incontinent, noticing some coughing or sneezing when they pass urine. And using vaginal hormones can be really beneficial, especially using vaginal DHEA, which converts to estrogen and testosterone in the vagina, but also the surrounding tissues. So it's a pessary called prasterone, or intrarosa is the other word in the UK. And that can be really, really useful. And that can be used with or without HRT. So again, every time we see a patient, we'll always be asking about urinary symptoms, bladder symptoms, any symptoms related to vaginal dryness or soreness, even if they're taking optimal HRT, because adding in vaginal hormones can be really transformational. There are some women that we see in the clinic who have been on HRT for many years, but they're on a tablet combination HRT, or they might be on a combination patch. Any combination types of patches or tablets contain a synthetic hormone, especially the synthetic progesterone. The only tablet that doesn't is Bijuva or Bijuva in the US, and that contains natural estradiol with the micronized progesterone. So that's body identical, but other types of tablets and other types of combination patches contain synthetic hormones. So often I'll change people to using the natural body identical hormones because we know that they're safer in the long term. So again, it's another option to just go through everything with your healthcare practitioner and make sure what you're on is right for you. We have to remember all this is just hormones. It's very basic medicine. We give thyroxine, another hormone, to women and men, and we continue it for life. We give insulin, another hormone, for life to people. There's a lot of debate as to, are these really life hormones, or are they just a lifestyle hormone? Well, they're biologically active hormones that have a myriad of really beneficial effects in our cells, and so they are useful. Obviously, we can live without them. We can live even if we smoke every day, if we drink alcohol every day, if we don't exercise. But we all know that not smoking, being moderate with alcohol intake or not having alcohol, eating really healthily, exercising regularly are all really good for our health. Some people might not choose to take a healthy lifestyle, and that's up to them. It's exactly the same with hormones. It's all about a choice. But I feel very strongly that as women, we should be given the information so then we can make the choice that's right for them. And I'm also not saying that if we take hormones, we shouldn't consider our lifestyle as well. This morning I got up early and I was going to do yoga really early, and then I was coming out of a migraine, so my head didn't feel clear, and then I started to work, and then I got really distracted with work, and then I thought, oh, do I really want to do yoga? But I did, and I just did half an hour's practice, and I felt so much better afterwards. So we should all think about looking after ourselves and improving our lifestyle as much as we can, whether we take hormones or not. So the short answer for this half an hour for the question, can I take hormones or not if I'm older, is yes, as long as they're natural, body identical hormones, and you're given them by someone who really understands menopause and hormones and has a lot of clinical experience and knowledge too. So I hope that's been helpful. I'll post it on my grid. Enjoy the rest of the evening, what's left of it, and thanks again for all your support.